the next little chunk here before lunch talking about transformation and running your program and change in your program. And like I said, VCDC does a lot of work helping organizations transform. And we've seen a lot of people struggling. Change is hard, right? And we're in this really, I think, unprecedented time, right? Like this is an incredible time in primary care, but it's also an incredibly challenging time. So, I don't know, I thought this was funny. I actually laughed. I mean, that shows what a nerd I am, right? That's cute. Can you see it? It says, this wasn't the pay-for-performance model I had in mind, and it's a tip jar. Yeah, see, my husband was like, what? I don't get it. But you guys get it, right? Yeah, so it's not easy, right, what we're doing. And it's transforming. And what you're doing today will probably, what you're doing a year from now will probably be different. So we're moving from a volume-based world to a value-based world, and it's a multi-year journey, and it's really like we have one foot in one place and one foot in the other place, and it's really hard, right? And this is not just in Vermont, as you know, like we've taught all over the country and worked all over the country, and this is everywhere. Everyone is really like, but we used to do it this way, and now I'm supposed to do it this way, but I still get paid in the old way, or I work with all these other people who only understand the old way. So how am I supposed to do this, right? So I wish I had some, magic answer for you, but just I think acknowledging that this is a challenge, and that we're all in, between these two places. Hopefully, it makes you feel a little less crazy, and I'm hoping that we're moving into that other world soon. But even, I was reading this book called Managing Transformation. Has anyone ever read this book? Bridges, William Bridges. If you haven't, it's really helpful. All of you should get it. It's on Amazon. Managing Transitions by William Bridges. It's all about, even when transformation and change is good, like where we're going is a good place, it is really hard. And there's actually a kind of strategic process. Like most people, I guess, think that, so it wasn't so good, so it's good, where we're going is good, so just boom, overnight we're gonna shift. But actually, and social workers probably, this would make more sense to you, or maybe all of you, right? There's a lot of letting go that has to happen of old ways of doing things, even when they were not good ways of doing things, right? There's a lot of unsteadiness. There's an actual, you have to kind of acknowledge that people have to let go of things. There has to be some discussion of that, right? So in your roles as managers and supervisors, you may want to think about that if there has been change and a shift in how people are doing things, to have a discussion about, what people are sad to see go and what people are happy to see go and what they might be struggling with, and just acknowledging that this is happening. Because if you don't acknowledge it, then people actually can't, they can't move on to that new place that we're going to. So, let's see. So what does this mean for you and your staff? So, you are tired. Some days you feel like things are changing, and some days you feel like nothing has changed at all, right? It's just same old. And I think my thought here is that you need an actual strategy to manage this transition. Right? You actually, as a leader, need to think about, what are the things I need to address? What do we need to talk about? We actually need a clear plan to do this successfully. And then you need time for yourself to think about what this means for you. How are you leading differently? Are you doing something differently? Do you need to? So maybe I'll ask, how many folks are working in programs that didn't exist 5 years ago? Or 5 or more years ago. So maybe half, right? So I'm assuming that those are programs that have kind of come out of like in a very big picture, like ACA came along and CMMI grants came along and federal funding came along to do this great care coordination work, and that funded that's why your programs probably came into existence, right? So this isn't a, like, we're doing things in a new way kind of thing. So you guys are doing things in a new way, but you still have all the other people you interact with who may be coming from an older system and are not used to interacting with staff like yours. Yeah.
Carla, I was just going to chime from the other direction. You know, I think it's one thing that's happening in healthcare, but also when you look at community-based organizations, what I've seen across housing programs, case management programs, social support programs is a push to be more involved in medical care.
Yes.
So, you know, clinics and hospitals are required to do this coordination, and that means the folks who are the non-medical service providers are involved in medical things in ways that we never had to be before. So there are two sides of the same transition.
Absolutely. Right, so the kind of traditional medical people, right, are doing new things, coordinating care, working as a team, integrating with community services and mental health. But right, the community service providers are being asked to work more closely with healthcare, be in healthcare, do reporting that's more related to healthcare, be on an EMR, all these things, right? So it's a lot of change. It's a lot of change. And what I was going to say is that the other folks who have been around more than 5 years, right, you definitely are moving from an older paradigm to a newer paradigm in terms of how you deliver your services. So let's just talk about, like, kind of some good things, right? Some good things about where we are today is that theoretically you're providing services to people who probably didn't get these services in the past, right? 10 years ago, I'm guessing that the people you're caring for did not have access to these kinds of services, right? Care coordination. Maybe there was case management, but not to the extent that we have care coordination and care management now. And you're part of a national movement that is, yay, thank God, hallelujah, paying for coordination of services, linkage to community resources, team-based care. Like, this is theoretically the direction that we're going in, and this is a good thing. We have to believe this is a good thing. And there's money behind it. But we have our challenges, right? As I said, we are still in a fee-for-service world, right? Most people are still paid for volume, for high caseloads. Doctors, for the most part, are still paid to see 25 patients a day. They are not paid to sit and talk with care coordinators. They are not paid to case conference. They are not paid to get on the phone with a mental health professional. They are losing money when they are doing that. So even with the best of intentions, they are still kind of stuck, right? It's a very tricky, and for them to take care of themselves, that's a real challenge, and to keep their doors open. Training and supporting staff. Stephanie and I were just talking about this. She works at SASH. She was saying how, there's lots of trainings going on across Vermont, but actually, wouldn't it be great if you guys could all be in touch with each other, and the trainings could happen for everyone, right? I mean, kind of like this is happening here, right? But how hard it is to see one-offs and, just a training in one place when everyone basically needs certain kind of core skills. And I can say that training, because I run a lot of them, is I think the single most underfunded and really misunderstood piece in this work. People who don't do this work, they're like, what kind of training do you need? Just onboard them and aren't they good? They don't get it. And why does this person over here need different training than that person over there? Well, this person's a nurse and she works with diabetic patients, and this person is a case manager and he works with homeless patients, and some things are the same, but some things are actually different, what they need to learn. So high caseloads, right? This is a problem everywhere. We're going to talk a little bit about ways we might restructure our caseloads to make them perhaps more manageable. There are many, many models for providing this kind of service. So if there's anything you leave with today, it's that there's no one model. In your packet on the left, you can look at it later. I gave you a handout that lists multiple models I think it says like elder
last
workforce.
handout.
Yeah, it's the last handout.
On
It
the
may
left.
be interesting to you. I put it in there just to give you some ideas if you want to think about how you provide services and how other programs are set up. There are multiple models. You have to understand your situation. Team-based care we know is a challenge, particularly across locations, right? And even sometimes within our own four walls. I've heard a lot up here working in Vermont this year about, like, we have so many programs, it's so great, and that everyone's kind of stepping on each other's toes, and we don't know, it's like, oh, we're both doing that, oh, no, neither of us is doing that, how do we negotiate that? And as you said, going from what we used to do to where we're going. So I'd like you to take, let me see, yeah. So you have a handout. It says Care Coordinator Program Assessment Activity. It's on the right-hand side of your packet. And just take, really not that much time, 5 minutes or so, and just fill it out for yourself. And these are just some questions to think about your own program and what you think is working well and where you think you feel challenged and your staff feels challenged, and then what you think success would look like in your program if everything, all the stars align. First of all, how was that? Any insights or thoughts while you were doing that?
I kind of go through this checklist on a daily basis.
You do. Good job. Okay, but that's good. That's great. Some people are just, like some people never think about these things, right? Like that sort of bigger picture, what's working, what's not working, and like what does success look like? So who wants to tell me some ways that they feel that their program is succeeding or they're doing well?
I wouldn't say it's
It's okay, you can say.
succeeding
It's
or
all right.
doing well,
Right, you're succeeding.
but it's conceptually, we're committed
Committed. That's cute.
to have a integrated community service. And one of the things that we've started is to have an orientation for all community partners staff, so that if someone from my agency is new to my agency, they will attend an orientation that is, it's put on by all the organizations take a part in the orientation. So the new person learns about the other agencies, the other programs in the county
That you partner with.
that
Yes.
we partner with.
I love it. Does anyone else do that? This is a great idea. I wish people in New York City did this. This never happens. Yes.
They can do that.
So-
So we've got a few million people. so
They can do it, but they don't do it, right? So building community, building team, face-to-face, all great. Wonderful. Yeah.
There is a team in Bennington that meets once a month, and there's about 30 representatives from various social service agencies that come. And there was a position that the hospital there formed, I think it's called the healthcare advocate or something like that. It was a full-time position. And that person essentially does care coordination and works with the ED and also with the case managers in the ED. And she works directly with people who use the ED as their primary care office.
Right.
And so they've had this program in place for a bit over a year now. And those people that they've done like a wraparound program for, they've cut their hospitalizations and their ED usage by over 50%.
Yeah.
So cost-wise, it's been huge that they've plugged them into primary care offices, which is where they should be getting most of that non-emergent kind of care anyway, so.
Right. So this is a model that is happening around the country, and sometimes the hospital is funding it or supporting it, or sometimes primary care or other organizations are partnering with the hospital. And it's pretty great if that person also has links and relationships with the other community providers, right? So there's that kind of warm handoff, and you catch people in the ER. So yeah, great. Other successes, yeah.
Our community really recently has, from the top all the way down, really kind of started to come towards the same vision.
Okay.
And we worked on like streamlining rather than duplicating. And
Yes.
it's been really powerful for my care coordinators to be involved in making those changes.
And can you say a little bit about how you streamlined instead of duplicating
We're
services?
still getting
right?
there, but I mean,
Yeah.
it's just, I mean, it's really been like taking the hours and days to do the value stream mapping and really follow a patient through the system so that they're not getting screened for the same things 50 times and they're not giving the same family and psychosocial history repeatedly. And I mean, we've been doing, I mean, like the Care Navigator rollout work with committees, so we're using that and just work within our community to change the way we communicate with each other.
Great. Yeah.
Well, I think particularly our pediatric department has been successful through an introduction to patient care coordination through the VChip project, which they've been participating in. And Ona has, as the patient care coordinator and one of the pediatricians, have been spearheading that project. And I think Ona would attest to the fact that it's been very successful, and I think now there are, 25 patients?
31 patients.
31.
Yeah.
We already have enrolled, meeting on a regular basis, connecting them with resources in the community.
Great.
So it's very effective as an introduction to getting a patient care coordination going in your primary care organization by getting involved in one of these projects.
Okay, and sorry, so I missed the kind of, what's the key intervention that happened here? Is there some sort of meeting or rollout, or
Can
what's
you
the?
explain it?
I guess I'm not sure the question, but I think what you're asking is, so this was initiated by the VChip project, you know, and I'm sure you know what that is.
I don't.
Well, VChip, it's through UVM, and they kind of spearheaded a care coordination for pediatric patients for complex care for pediatric patients. And they have this whole training seminar, kind of like we do with this program as well, very similar, but more geared towards the younger folk. Which the training was actually amazing, and it's been amazing right along. But I think what we've done is we've obviously taken their model and kind of made it our own, and it's been pretty neat. The families are really receptive. They really want the care coordination. And did that answer any of your questions?
Yes. It's more like I want other people to be able to get whatever nuggets of good things happened, so they have ideas to take back with them.
Are there anyone else in primary care here? Is there anyone else in primary care?
Other folks in primary care here?
Right.
Yeah. So Vermont Children's Health Improvement Project, quality improvement for pediatric practices across the state. They've been spearheading a learning collaborative for care coordination, shared care planning with families, and connecting to schools and other resources in the community for a couple years now.
Great.
And another, somebody mentioned Care Navigator, care management software that's being piloted by One Care Vermont, one of our ACOs, and can be used as a tool for shared care planning across organizations.
Great.
Can I add that, Erin, I would see that a little bit differently, because I think, the first person, bless you, who mentioned that, though, I would take that, and you said, is anyone else doing something like this? And I think it's important that these learning collaboratives get mentioned, because I keep looking at Robin across the room and Leslie next to me, because we have a couple really important learning collaboratives that are happening that really are doing what you mentioned. And I want to make sure that the people in this room are thinking towards how do we continue the great things that have started. So the pediatric care coordination learning collaborative has been going on for a couple of years, and that helped to inform and shape the integrated care management learning collaborative that has also now been going for a year and a half. That when people mention Care Navigator, that's really just the software for shared care planning that's really coming out of how do we care coordinate around complex patients, and that's happening in 10 different parts of the state, 11 parts of the state, and not Bennington, because Bennington already had figured it out on their own. So we've got these really cool initiatives going around the state that have integrated partners coming together. And I don't know if economic services is at the table in any of the locations, but if they're not, should they be and when are they involved? But it's really about how do you bring all the right people together around complex patients that we're not duplicating. So we do have this happening, and then we need to make sure that it's sustainable and we don't lose the great work in all these communities. And we're all talking about that, but it's some really great things happening. I just want to make sure when the learning collaborative part of it falls away, that specific funding, that we still keep the great work and we have some oversight and coordination around it.
Yeah. Okay. Great. So let's talk about challenges. I'm sure we're gonna, fill up my whole pad over here. Just give me some.
Time and money.
Time and money. Yeah.
Prioritizing needs.
Say it again.
Prioritizing needs.
Prioritizing needs. Okay. For your staff, right? Right. Yes.
Getting away from being crisis driven.
Moving away from being crisis driven. Right. Challenging.
A challenge for our staff is, I think we're delivering a really good service, but the way it's been done is that the service coordinators feel like they're everything to everybody and will fill in any gap that's there.
Right.
And we are going to have to change this way of working because the labor laws are changing, and these salaried employees next month are going to be hourly rate employees, and we cannot afford to pay them to do the work that they're doing. And it's a real slap in the face for us all, because so we need to help them with boundaries. We need to help the rest of the teams that they're working with understand the boundaries, because they've been doing things that really are not their job, but they've been wanting to help.
Right. So this is a great. Good example of, so how do we take something like this, right? The labor laws are going to change. Are other people going to be affected by this? I'm assuming you're all going to be affected by this. Maybe not. Maybe other people were already being paid hourly, but anyway, it's a good metaphor for other changes. How are you going to present this? How are you going to present this to your staff in a way that?
Folks, can we bring inside conversations, and also just a reminder about technology? Please, if you need to answer email, step outside.
Thank you. Great. Thank you. How are you going to talk to staff about this in a way that's going to get them feeling like this could be a positive change as opposed to a negative change? Any ideas? So she's saying staff is doing everything for everyone, right? And that, I would say, is the crux of what is very wonderful and challenging about being a care coordinator, right? So we're constantly having to make boundaries. But how do we do this,
Think about burnout.
Yeah? So what would be a message you could bring to your staff? Right? Because what I heard, and this is not a criticism of you, this would, is, they're doing things that are not their job. But I might say that if you came with that language, that people might be a little bit like, well, I do a great job, and I take pride in what I do, and I don't just spend 10 minutes with my patients, I spend it. So how are you going to bring this message in a way that is going to get them on board?
Well, I would want to have a conversation with them and not at them, but really focus it around how can I help them restructure their day or their workflow, or how do we identify the things that they can and should pass off, and who is that person, and really use it as an opportunity to kind of restructure on a grander level.
Okay.
So that everybody's doing the right kind of things at the right time, in the way that makes the most sense.
Okay. And other thoughts? Yeah.
Well, I'm not sure I understand it, but it sounds a little bit like the laws coming from a boundaries and protection of too much time and work. So knowing that that's a good thing from, bringing it with a positive light from that perspective. Now we just got to figure it out, but it's coming from a good spot.
So the reality is, for us, we've known this change is going to be happening for months and months. So we started our discussions a long time ago, and the initial reaction of the service coordinators was, how am I going to like make things keep like
Right, how is
this
that
gonna
possibly
happen?
do it? Yeah.
And now, as situations have come up and we've had time to, discuss them and work this out, I think it's feeling like an enormous relief. And that it is, sometimes you need a boundary thrown in, like a legal boundary. And so it's been helpful.
Right.
I think it's going to be positive, but it took us all these months to really get our head around how to do the work, not feel bad about asking somebody else to do, something, and I think it's going to help burnout tremendously.
Okay.
Did you
want to say something?
Yeah, I feel like in the work that I've done with a lot of care coordinators in SASH and in previous work with homeless prevention, I've spent a lot of time talking to SASH, well, more recently with SASH, like these people our participants got to 85 without us. So what were their strengths to get them to that place? And then I think that it takes a lot more time in the upfront, but a lot less going further to to shift the way you look at your work as in how can we show them that they can do it themselves and what are the things they can do for themselves, because if we're always coming in to save the day all the time, it's not ultimately helping the people that we serve in the long run.
This is actually what I was thinking, is that like a kind of positive spin on this is to remind people, right? And I always say, like we all went into this work, like not because we want to make a lot of money or be famous, or we went into this work because we want to help, right? At the bottom, at the base, that's what we want to do. That's what our staff wants to do, and we have a lot of our self-image is very caught up in like I'm a helpful person and I don't abandon people and it's really tied up in that. We don't want to be thought of as bad people, and our staff don't either. It's just very hard to limit the work. But at the end of the day, kind of going back to this parent analogy, it's not good for our patients for us to do, or individuals we care for us to do everything for them. It's not good, right? I always say this every training. I say, so if we do a really good job with our work, what happens to the patients we care for? They what?
Oh, no.
What happens? They leave. They leave. It's good to remind your staff of this. Now I know there's some individuals who will never leave, but still the vision is that they are becoming more empowered and they are gonna take responsibility, get better, do whatever they need to do, and go on with their lives.
I have one more quick thing too, that one area that I support, there's a lot of boundary issues there, and one thing they were told is you are not allowed to put participants in your car. And that was one clear boundary that their supervision had for them. And I was told by multiple staff in this area, I'm so grateful they said that to me.
Yes.
Because then I can say no, and it's not my fault
Yes.
that I can't help. It's
Right.
my boss said I can't do that.
So this is a great point, right? This is like, it's so helpful sometimes, right, when you guys as the supervisors, when you are, like you do people a favor sometimes when you say like, no, you're not allowed to do this, right? It like a parent saying, I'm sorry, I don't care what all the other kids are doing, you're my kid and you have to be home at 6. End of story, right? That's, so you took all that responsibility and angst away from them. Okay, one more challenge. Maybe we'll move on. So let's talk about vision for, what is my question that I have here? So what would success look like? In a perfect world, your program is doing wonderfully. Or maybe in even an imperfect world. What does success look like? What's the end goal? Yeah.
For our program. So it was interesting to me because on the first question, how do we know it's succeeding? And I could answer it to say we're achieving the AAA because we've shown cost savings, health improvement, all that stuff. But really for me, success has looked like, when we talked about this recently, is that people say we couldn't be helping patients in the way we are without SASH. There's this acknowledgement and recognition from other organizations in the medical community, and that feels like success. But I feel like what success for us would look like in the future is the ability to serve more people, to help more people, to expand and grow to other populations and to more people, and to also just have wider understanding and recognition. I guess that's it.
Great.
Yeah.
Great. So you're valued, appreciated,
Right.
needed, and you can expand
Yeah.
to reach more folks.
Yeah.
From a different perspective, to me, success also looks like sustainability, because most of what I do is grant funded.
Oh, yeah.
Yes, isn't that sad?
Right.
To say things like that, like that you'll be around in a year, right, or in 5
But I mean,
years.
it doesn't have to be negative. I mean, I think that we can prove the value of what we're doing, and so then the next step is how we pay for it. And that's not a bad thing. I think
Yeah.
it holds us accountable.
Okay.
But I
Okay.
think it's important.
Okay.
That's a positive reframe.
Yeah. other. Yeah.
Something similar to what she said, just positive, I mean, just going back to the, I guess, the bottom of it, is the positive patient feedback, meeting patient needs, and, some seeing success stories.
Okay.
Seeing patients move out.
Good. So what you Ona, right?
Yeah.
So remember what Ona said when you're thinking about proving your value to others, right? And of course we have reports and we have data and all that stuff, but that's really important, and I have seen this to be true. Stories, narratives about the people that you have helped. Collect them, have people write them down, have your staff write them down. Don't lose this stuff, because, right, the people who don't do this work, they have no idea. They have no idea. And numbers will speak to some people and you need data, but stories also speak to many, many people. So that's a great point you made. Other visions of success?
That we would have the data to be able to.
I'll get you there.
Yeah.
That you
That's a
actually
good
have
challenge,
some data.
measurements.
Right, and we're gonna talk about measurement in just a few
I
minutes.
mean, we have it at a state level, but we don't have it at the local level, and
Right.
there's still some skepticism about that.
Right,
Mhm.
okay, that you'd have some data, right, that could show what you're doing. Yes. Oh, yeah.
This is super pie in the sky, but
That's
the
okay.
gaps are identified and funded.
And can you say a little bit more about that?
So like, we all know that transportation is one of the
Oh,
hugest
yes.
issues in the state. Like,
Yes.
how do we get people from the backwoods and the mountain
Yes.
down to their provider, or down to the services that will support them?
Right.
For
Isn't
example.
there some foundation that wants to fund that? I keep thinking there's some,
There's a V-Trans grant.
Right.
So there's, I know, $5 million.
We all gotta put our heads together.
Or like there's like choices for care that keeps getting, reduced. And so people who might need to be on that program might not be able to because there's such a long waiting list and the need is there and they qualify and they can't have it.
Choices for care is, sorry.
I don't know how to say it.
Long community.
care.
Is that like, so you don't have to go to a nursing home or the hospital, you can receive care in the home? Because I've heard this a bunch of times here before. Yes. Yes, let's expand choices for care.
You're a Vermonter now.
Yes, that's what we want. What else? Anything else?
I mean, I'll put a plea in for Blue Cross. We just want to work with people. We need to break down barriers. Just because we're insured does not mean that we don't have the same goals, and
Right.
we want to be partners. We have the same agenda. We don't have some weird hidden agenda.
Right,
That sometimes people think, oh, you're from Blue Cross, we don't
Right.
want you here. So we just
We're very
want,
much focused.
we're very
Right.
focused on this.
Yes.
On that.
Yes.
Can I just challenge you for a second on that? I mean, this is a genuine question, because I've had Blue Cross insurance and had a hard time in Massachusetts and had trouble getting my own care needs met.
Very different information.
Yeah, maybe so, but if you guys are the care quality focused wing of an organization that is required to make money for their shareholders, does that not put you in a
So we're not
squeeze or a conflict of interest in some way?
So we're not for profit.
So let's
Okay.
just, and yes.
Independent, non-for-profit
Okay.
here in Vermont.
And yeah, we have a cost. We're looking at the triple aim for everything, but really it's about population health and how people experience care. And it's not about a diagnosis. It's about looking at the whole person and the social needs and how they access healthcare. And that just because we have a commercial population who people think have resources, they don't. And we struggle with that really hard, and we need to, we fund the blueprint and we fund the CHTs in Vermont, and we just want to partner and see how we don't duplicate services,
Right.
but
we hear a lot of stuff from our members after they've been to the doctors, or we just want to say, this is what we're hearing. When you see this person, can you address this and not have it be about, why are you calling me Blue Cross, you know? And having to break down those barriers time and time again. Every success story makes it easier, and you know, telling the stories is huge, 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 huge. I mean, people are amazed at what we do from the insurance company's perspective. We're just working with people like everybody else.
I just think that when you're working in a context, I mean, when I work for community-based organizations, when insurance companies or pharmaceutical companies come in, they have their own agenda, and usually it involves in some way something that helps them make money and is good PR for their company. And so whether that lines up with what we're doing or not, to me it's an important question, because I agree with you. If we can collaborate across sectors, that is really beneficial. But I think that I don't have the greatest experience with insurance companies. Well, that's why I'm raising it, because I'm sure other people have some of the same skepticism.
And I would challenge you that just because a company makes money doesn't mean their end goal and their output is not a positive, healthy behavior for people. Having worked for I work for a nonprofit now, but people use nonprofit, oh, that means that's okay and all the profits are doing it.
It's not that clear cut.
I worked for a for-profit housing company that did amazing things, and so I challenged that. Just because that's the title of the company doesn't mean, that's the way the company works, doesn't mean they're doing bad work and they're not having a...
No, I just think that the ethics of the insurance industry is a whole other conversation that we don't need to get into. I'm gonna reel myself in and give it back to Carly.
I would say that probably for, you know, for folks who work for a payer, like that there, and I'll say this in a little bit, but you know, you really want to go out, you probably do this, I'm guessing, but you really want to build personal relationships with people in the community. Like if I'm the midwife and I hear that a care coordinator from an insurance company called my patient, yeah, I'm suspicious. I'm wondering why they're calling my patient. If I meet you and you seem like lovely, smart people, you know, then I hear what you're doing and I see, you know, then it's perhaps different, right? So there is a historical kind of legacy that you're pushing
Yeah, we need
against.
to break that historical
Yeah,
barrier.
but in person is usually the best way to do that.
And I would just point out that these guys will come to meetings if you invite them. I mean, I don't know you
Right.
guys personally, but Tara's driven up to St.
Yeah.
Albans.
Tara is
Right.
Right.
Come to me
Yeah.
and talk.
What's up?
All right.
I have one thing that this may be controversial to say, and maybe I don't even have all the information I need, but I've had some experience with some of the agencies that aren't used to giving reports back. Like they won't say how many times they tried to call them, and if they didn't get them, we'd like to know. If they got a hold of the person and the person declined, we'd like to know. And if they quit the relationship, we'd like to know. And a lot of the agencies that I've been working with now in my extended team, they just look at me like I have three heads. Like we don't even have a mechanism to report back.
Well, I think that's so important because the patient now has so many people invested in this kind of stuff that a lot of times, you know, the practice is doing panel management, the practices are reaching out to them. Care coordinators from agencies are reaching out to the person. They're getting a letter from this, they're getting a phone call from Blue Cross, they're getting, so how do we come together to kind of collaborate so that it's a little bit more coordinated and patient-centered, and this person isn't like, oh my God, everybody wants to, you know, population health and care manage me now.
Right. Yeah. I think that's the challenge, and I don't know how we get to success on that, but that's kind of what I was saying in the beginning of the day, my ultimate goal. How do we get you guys to the right meetings? You're not calling it. Exactly what Robin said really, really well. Yeah.
Okay, good. We're going to keep going. This was